Okay, so I'm here to talk to you guys about adrenergic drugs. These are going to be the drugs that are going to either decrease or increase the action of norepinephrine at the adrenergic receptors. I'm going to look at the targets first. So the targets of the sympathetic nervous system, if you will, are the heart, both the both the myocardium and the electrical conduction system are going to be influenced by the norepinephrine hitting those beta-1 receptors in the heart. The alpha receptors are found in the vasculature. These are the alpha-1s, and they are completely controlling the blood pressure. The sympathetic nervous system is completely controlling the vasculature, mostly via alpha receptors, but there is some beta receptor activity as well, beta-2s. The bronchular smooth muscle of all hollow organs, including to some small degree, the blood vessels, but we really think about the blood vessels in our class and really being more under the control of the alpha receptors. But beta-2 receptors are going to be found in the walls of our smooth muscles of all hollow organs. Also, we think about the beta-2 receptors playing a role with metabolic rate, so increasing metabolism when we have drugs that are adrenergic agonists. So those are our most important targets for these drugs. How they're going to work, the agonists, is they're either going to stimulate the release of norepinephrine from storage vesicles on presynaptic neurons, or from on the postganglionic neuron of the sympathetic nervous system. Drugs like ephedrine and amphetamine do that. We also can inhibit the reuptake mechanism, keeping more norepi in the cleft. Drugs like imipramine and cocaine do that. We also can inhibit the breakdown of norepinephrine, leading there to be more norepinephrine available to hit these receptors. And the breakdown of norepinephrine is done by two enzymes. The primary one is monoamine oxidase, or MAO. It's called the MAO-B receptor, and they're all over the place. And they break down norepinephrine when it's removed from the synapse back into the neuron that released it. Another enzyme that breaks down norepinephrine is COMT, C-O-M-T, which stands for catecholamine methyltransferase, and that's another enzyme that degrades norepinephrine. So, and that's not a primary action of drugs, but it's another way we get rid of norepinephrine. So whether we increase the release, or we inhibit the reuptake, or we decrease the breakdown, all of those have the net effect of increasing the norepinephrine available to hit our beta-1s, beta-2s, and our alpha receptors. So when we look at the drugs, there's different ways to kind of break these down. There's the non-selective adrenergic agonist, meaning that they're going to hit all those receptors, the alpha-1 receptors, the beta-1 receptors, and the beta-2 receptors. A great example of this is epinephrine. Dopamine is another example of this. Dopamine, when it acts peripherally, it hits the same receptors and it gives you a sympathetic stimulation. So these are used probably most notably in cases of severe allergic reaction where we really need to see an opening of so I'm thinking like of an anaphylactic kind of a situation here leading to shock. So that at the beta-2 receptors can open up the airway, reverse the bronchoconstriction we see with the allergy, cause a lot of vasoconstriction, so it's great there for situations of shock and circulatory collapse. Dopamine is a big one there. Also increasing cardiac output in a case where the heart's really not doing much of anything, dopamine will be used. So some of you who may work in an emergency room, someone's having a major heart attack, they're basically throwing everything at them, and one of which is dopamine to increase the cardiac output. So those are non-selective, meaning they don't differentiate between the alphas and the beta receptors. Then we can kind of break it down by receptor subtype. And first, let's look at the alpha-1 agonists. Of course, we're thinking here specifically of the blood vessels. So these guys are going to be used therapeutically anytime you need to vasoconstrict. These things will reliably vasoconstrict in a major way. So in red, you can see some of the reasons why you might want a vasoconstrictor. Some of these are used more kind of locally, like the nasal sprays. Oftentimes, nasal sprays are alpha-1 agonists, and they're delivered specifically to the nasal mucosa to cause some contraction, of those vessels, which decreases the perception of the congestion. It doesn't really do anything for the cause of it. Increasing blood pressure, of course, because they're going to increase total peripheral resistance. They're used as an adjunct to local anesthetic, mostly because by vasoconstricting, you inject the vasoconstrictor, and then you can put the anesthetic downstream to the vasoconstrictor, and the anesthetic will stay there a little bit. And then there's topical hemostatics, are agents that can be used topically to vasoconstrict and stop bleeding. So those are all potential reasons why we would want to give a vasoconstrictor. There's also alpha receptors, alpha-1 receptors in the radial muscle of the eye. The radial muscle of the eye are the ones, again, that the fibers are arranged like spokes of a wheel. So when you administer an alpha-1 agonist, that would reliably cause pupil dilation for eye exam, and those are usually given topically. Also, if somebody's got like a lot of redness or congestion in their eye, the topical drops are vasoconstrictors, and those are alpha agonists as well. One thing to think about when we vasoconstrict is, in the cases of congestion, when you vasoconstrict, that oftentimes, and this kind of gets a little bit ahead of what we really need to talk about, but when you vasoconstrict, what that does is it decreases blood flow to an area, of course. And if you do it long enough or profoundly enough, when an area is underperfused, oftentimes when those tissues become hypoxic, it kind of sets off this inflammatory reaction, which causes more inflammation, which causes more congestion, so it sort of spirals out that way. So it's sort of good to note that for people who are using these things either as eye drops or as nasal, as a nose spray for nasal congestion, that the congestion can actually get worse, especially if you try to stop taking the medication. And then, of course, they're going to increase blood pressure if you're not using them for that purpose. So anyone that has any risk with an increase in blood pressure, even like if you're giving these things topically, for example, for an eye exam, if somebody has hypertension, you'd probably want to think twice about that for that reason, because they will cause an increase in blood pressure. The Beta1 agonists, an example of a Beta1 agonist is dobutamine. We're going to think of these as having an isolated effect on the heart. So you can see therapeutically, if someone's had cardiac standstill, they've had a heart attack and their heart's not able to pump effectively, a Beta1 agonist will probably be used, as well as dopamine and, oftentimes a whole bunch of things all at once. In cases of heart failure, we might think of this. If somebody has an atrioventricular block, which means the transmission of the impulse from the atria to the ventricles is inhibited, a Beta1 agonist may be useful for them. We'll talk about antiarrhythmic agents later on in the cardiovascular section as well. Shock is another example of this, mostly just because of getting the heart rate going. You would expect as a side effect, of course, that to see an increased heart rate, to see an increase in blood pressure, and potentially see an increase in arrhythmia. An arrhythmia is just an abnormality in either rate or rhythm of the heart. And if you give somebody a drug that makes their heart beat faster, you can potentially precipitate an arrhythmia. The Beta2 agonists, these guys are going to block specifically the Beta2 receptors. So where we really think about them is in two conditions. One is with asthma and the ability to open up the airway. Albuterol is kind of the prototype of the Beta2 agonists. We'll talk more about this when we talk about the respiratory system and asthma specifically. But both asthma and COPD, right? We talked about with COPD, we might use a muscarinic antagonist instead, but either one of these is a possibility. And then another use for Beta2 agonists is to use in cases of preterm labor when someone's having premature uterine contractions. These will relax the uterine smooth muscle. Of course, we're going to expect potentially to see an increase in heart rate and also palpitations. We think, it's not Beta1, it's Beta2 selective, but there is some crossover. The effects at the heart aren't going to be quite as pronounced as with a selective Beta1 agent, but you're still going to get some cardiovascular stimulation. So we really need to be careful with people who have heart failure, people who have dysrhythmias, or even people who have already hypertension. You might want to think twice about that. So the most important site of these drugs is really the lung, and the most important use of them is really asthma. This is our primary medication, or we call it a rescue drug for asthma, the metered dose inhaler, the albuterol inhaler, opens the airway beautifully for most people. So we want to be careful, again, people who have angina, which is chest pain due to the inability to supply their myocardium with enough oxygenated blood to meet the demand. And the reason why this is these adrenergic agonists, whether they be alpha-1s, beta-1s, or beta-2, are contraindicated in people with angina is because you're going to expect the heart to have to work harder with any of these agents, whether it's because they're having to overcome the elevation in blood pressure or because the contractility is actually up. All of those will increase the work on the heart. We're going to be careful with people with hypertension and also people with hyperthyroidism. So the thyroid, of course, is our metabolic center. And when somebody is hyperthyroid, they're already kind of ramped up. And because of the action at the beta-2 receptors also increases metabolism. We want to be very cautious with people with hyperthyroidism because that can put them over into kind of a toxic situation with this metabolic effect. And sometimes that's referred to as thyrotoxicosis. So anyone who has Graves' disease, hyperthyroidism, thyrotoxicosis, you're really going to want to be careful with them with these adrenergic agonists. The beta-2 is what we really think about. But again, they're oftentimes with hyperthyroidism, they're already getting palpitations. So their hearts they're already working harder cardiovascularly. So I would kind of steer clear, if possible, of all the adrenergic agonists with people with hyperthyroidism, unless, of course, you have good reason to do otherwise. All right. So I'm going to quit here and come back one more time to talk about the blockers. So we'll do that in the final video for this particular unit.